Martinez and I'm a paediatric dermatologist, and I work in a big teaching hospital in London, Great Ormond Street Hospital, and I also work at the Paulin Hospital. I only see children, babies from birth up to the age of 16. The ones that are most easy to recognise are the immediate reactions, and they're driven by an IgE pathway, and that looks very similar to when you rub against a stinging nettle and you get a little swelling. That's urticaria. And then if it's more significant, you can get some swelling known as angioedema, and that is very localised often to the area that's been in contact with the protein here, the cow's milk protein, but it also can be widespread if there is a severe reaction. The most common reactions though are either delayed, which are driven by Ig and non-Ig, which is atopic eczema or atopic dermatitis. And in children with cow's milk protein allergy, this is a really common condition that affects over half of infants with cow's milk protein allergy. This can present nearly always initially on the face, and that can present very subtly with just dry patches initially on the cheeks. And very typically at that point it's not itchy or symptomatic. As it progresses and as the eczema or atopic dermatitis gets worse, then it particularly becomes itchy and red and raised, and sometimes even little blisters can develop, little vesicles. And as the child rubs the skin, the areas can break down and become red and also infected. Characteristically, atopic dermatitis, atopic eczema on the face spares the nasal labial folds, which is the little area here between the nose and the mouth. It's very characteristic of atopic dermatitis. Now, as the eczema progresses, it moves from the face, so it involves the face, it also involves the body. And typically it presents on the body initially in the early stages as sort of round patches, which are scaly and again not itchy to start with. And that often gets misdiagnosed as ringworm. As eczema progresses on the body, then it tends to spread to involve the arms and the legs and the trunk. And at that point, when it's widespread, it's extremely itchy. And it's very characteristic when you undress a baby with widespread eczema is that they immediately start pulling and scratching at their skin. And that is sort of widespread atopic eczema or widespread atopic dermatitis. The reason why it's always worse in the face is because that area gets a lot of exposure to allergens, saliva, cold, food. And so that's often, if you have bad eczema in an infant under the age of 1, it's nearly always worse on the face. And not only that, in studies in the last couple of years, we know that the skin on the face doesn't mature until over the age of 1. And so the natural lipid production in that area is again much less than in the other parts of the body. So it's often a more problematic area. So it's very difficult sometimes to tell whether atopic dermatitis is driven primarily from a food allergy or not. It's easy to know whether it's an immediate allergy, because then you'll recognise the hives that we talked about, these swellings. But if it's a delayed reaction or a mixed reaction, then what you will see is atopic dermatitis. So it's very difficult to know whether, when you see a child with atopic dermatitis, without doing investigations and tests, whether there is an allergic component, unless there's this immediate history. And that's why it's important to take a really good history from the family about other symptoms besides the atopic dermatitis. And those ones which are the really important ones is to ask about feeding and any gastrointestinal symptoms, any respiratory symptoms that are associated with the condition. So it's a sort of, you have to have a holistic approach to really be certain and sort of draw out different aspects, not just looking at the skin. The management of atopic dermatitis is complicated. There's a sort of a ladder, a stepwise sort of progression. What we initially would recommend would be pH neutral products, because they reduce the drying of the skin, and emollients, sometimes cream based during the day that are a bit lighter, and then thicker emollients in the evening, which are typically ointments that come in tubs. I think it's really important to know when they come in tubs how to apply these ointments, to not double dipping hand back and forth, because the risk of infections and contamination is high. So using them in the correct way is really important. And if that isn't helping, to have a low threshold to go up to the next level of treatment. And that is normally topical steroids of different concentrations. The other thing that I think is really important is control of eczema on the face, because we know through through sensitization of foods through the skin, particularly on the face, will predispose the infant to developing allergies. So it's important to control the eczema in that area. So the use of steroids regularly can potentially have side effects of thinning the skin. But with the new calcineurin inhibitors, which now are licensed under the age of 6 months and above, we've got these new topical treatments that won't thin the skin, but will allow us to manage the eczema safely, particularly during weaning, when we want to keep the skin really well controlled. When a child has an infant very severe atopic dermatitis and the skin is very red and open and weepy, it's really important to exclude an infection, and that can be difficult to know without doing skin swabs. So I have a very low threshold if the skin's red, open and sore to do a swab, because not only could there be Staph aureus, which is a common bacteria that lives on the skin, but in infants with bad eczema there can often be a streptococcal infection, and so without a swab you can't be confident that it's there. And without treating that with oral antibiotics, you can't get rid of the streptococcal infection. So it will mean that the eczema will be very difficult to manage. If you have an infant with cow's milk protein allergy and moderate to severe atopic dermatitis, they should be referred as soon as possible to a paediatric allergist and a paediatric dermatologist, because the management is complicated and complex and needs to be done as a team with a multidisciplinary approach. And the reason is because it can prevent comorbidities in the future for this infant, and so the care that they get in the first few months of life is really, really important.